My name is Josh Wiener. I'm from RTI International in Washington, D.C. And for this plenary session, we're going to be talking about long-term care financing. Long-term care financing is one of the most contentious issues in long-term care because at its heart, it's about the role of government and what the balance should be between individual responsibility and social responsibility, collective approaches. And certainly in the United States, while we've made a lot of progress in long-term care, we've made no progress in terms of financing. And so with that in mind, I'm very pleased to introduce Heinz Rothgang from the University of Bremen. Heinz is a professor there and the director of the Center for Social Policy Research. Heinz.
Thank you very much, Josh. Okay, good afternoon to all of you. I think the microphone is working quite all right. So we can start talking about long-term care financing. I've put a quote from Karl Valentin on it. Everything has been said, but not by everyone. And that's what I think what's my job, to repeat what we have discussed for 2 days and in fact discussed for several years from now on, and try at least to organize it a bit. And if we go back to the very basic of it, if we talk about long-term care financing, I'm talking about financing rather than funding, because later on I will distinguish between pay-as-you-go systems and funded systems. That's why it's financing here. And we have 4 sources of financing. That's it. More we don't have. We can finance it out of pocket, out of our regular income, or out of the assets we have accumulated over life. We can finance it via private voluntary insurance, and that's, so to say, the private bits. And then we have the public sources, that social mandatory insurance and taxes. More than that, by and large, is not available. So if we talk about financing long-term care, we talk about the balance between those 4 sources of financing. And the questions we ask, on the one hand, they are positive. What is recently used in different countries? And the other thing is normative, what should be used. And I must admit, during the presentation, I am quite often tended towards the normative question, because we have heard a lot of different systems in the last 2 days, and I think it's not possible really to do all the systems justice. So I will rather try to tackle the broad issue with a normative hinge. So, and that's the agenda that comes from that. First question, do we need public involvement? Do we need public welfare state financing, or can we leave it to the private citizens, to the private sector? And my answer to that is yes, we need public involvement, and I'm going to try to argue this case. Second question, is there a one-size-fits-all solution? And the answer to this question, for me, it's no, because the solution we choose for our countries has to fit to the rest of the welfare state conception of this country. And as I'm trying to argue, we have different conceptions. And what we should always do is think, what are our goals, what are our conceptions of the welfare state, and from that on, answer the question how it should be financed long-term care. Third, what are the major challenges for our tax-based and social insurance systems? I'm just only repeating those. And then the fourth question might be the most interesting one. How can different means of financing be combined? Because that's something I observe in the last couple of years in different countries, that we introduce new mechanisms that are distinct from what the main mechanism in the respective country is. And in the end, of course, there's a summary where I try to bring home the points I've trying to make. So, do we need public involvement at all? As you remember, my answer to that is yes. Why is that so? First, the lifetime risk of need of long-term care is very high. That's something that we, I think, are all familiar with. But in the general public, there is still something like the 4% fallacy, the idea that only a small minority of people is in need of long-term care, which is simply wrong. I've put up just a few figures here from the US. What are the lifetime risks of nursing home care? And you can see from those studies, most of them are quite old. It's between 25 and 40%. So with a probability of 25 to 40%, we need long-term care, nursing home care at some point in our life. You can say, well, that's from the US, and there is not a very sophisticated home care sector, so that might be high. So it would be more interesting to know how high is the probability of being in need of long-term care of any kind. And here I have some figures from Germany, where we have a fairly strict definition of being in need of long-term care. And nevertheless, you see the probability of needing any kind of long-term care at some point in life is 50% by men and 70% by women. That means more than half of us in this theater here will be in need of long-term care at some point in our lives. And that's what we are talking about. So long-term care is a social risk with a high probability, and we cannot say, well, that's something we can ignore. Okay, it's an important risk, but can we pay it out of pocket? And the answer to this question, once again, is no, because the cost of formal care, particularly nursing home care, exceed the income of the average pensioners. Once again, figures only from Germany and from the US. In Germany, you see that are the daily rates of, or here the monthly rate of nursing home care. In Germany, we distinguish between 3 levels of care, 1, 2, 3, with more intensive need of care with the higher levels. And you see the rates, the monthly rate, average monthly rate are between 2,400 euro and 3,300 euro per month. And of course, the average pension is about 1,000 euro. So the normal pensioner cannot afford that. The same is true for the US, where I only got this figure, 75,000 US dollar then per year, which is about 3 times as much as the average disposable income for a person aged 65 years. So we cannot finance it from out of pocket from our income. You can say, well, of course, then there are assets. What about financing it via assets? Well, lifetime cost may exceed pension plus accumulated assets easily. Once again, some figures from this time from Germany. That's from a study where we followed 2,000 people who became in need of long-term care in the year of 2000. And we followed them for 12 years and added all the expenses that happened then. After 12 years, 90% were dead. For the rest 10%, we did some estimates. And what came out of it is here that you see average lifetime cost in Germany for long-term care are 80,000 euro in women and 40,000 euro in men. And in the session before, Raphael presented some figures for England, which were quite similar. So these German figures are not out of range, but I think that's what we can expect in Western countries. That average figures, if you then look at the distribution, you see that a considerable amount, I would say, let's only look at the 20% with the highest expenditures. 20% have expenditures above 55,000 euro, but these are only the expenditures of the social long-term care insurance. About the same amount has to be added for private insurance. So we can say about 20% of the people in need of long-term care have expenditures, lifetime expenditures that exceed 100,000 euro. Once again, that's very similar to what the English colleagues have calculated for England. That means out-of-pocket financing won't work so far. So what can happen then? You remember the four sources of financing. The next question we can ask is voluntary, actuary, private insurance enough? And my answer to that is no. And we can look at some figures here. How many people do hold private insurance? In France, that's about 15%. In the US, about 5%. In Germany, 4 to 5%. That's private, voluntary, long-term care insurance. And these percentages are for population over 40 years. That means 40 years and older. And that's a minority, a fairly small minority. The same results if you look under the market and ask what's the private long-term care insurance spending as share of total spending. And you see only in the US you reach a figure of 7%, and in all other countries it's much lower. That means at the moment private long-term care insurance is a minority product for a minority of people, which covers only a small share of long-term care expenditures. Of course you can say, well, that's due to some market failure that we can take on board and heal and do whatsoever to increase that. I doubt it. And just to look into other areas of social policy, if we look at the only private healthcare system in the world, in the Western world, US, we see that before Obamacare we had 40 to 50 million people uninsured and the same amount of people underinsured. That was in healthcare, and everyone, of course, is aware that he might become ill. Most people deny that they might become in some need of long-term care. That means even in this market, the number of uninsured, or the quota of uninsured, 1 in 6 US citizens, is quite high. Another example, we can look at in the German pension insurance market. In 2001, we changed policies in pension and said that the public pension will no longer suffice, that people should buy private pension insurance, and it has been subsidized. Now, about 10 years later, the figures stand at about 12 million people who bought this private pension insurance. That's 1/6 of the population and 1/3 of the working population. That means that the vast majority of Germans did not buy pension insurance. And I think there is some reason for that, why we see in pension, in health, in long-term care, only a minority of people buying private insurance. The reasons are, you're all aware of that. People are not aware of the need of long-term care. That's something, of course, we could change, but at the moment, I think it still holds. Then what we can not easily change, low-income people can't afford it. Groups with high risk don't get it, at least if there is medical underwriting, and there is the problem of adverse selection if there is no medical underwriting. That means there are some factors that are imminent in the market that guarantee, so to say, market failure. And I think we are quite safe to say that if we rely on private voluntary insurance, we will never cover the whole population or anything that comes close to that. Which is the reason why I agree to the OECD when in its 2011 report it said private long-term care insurance has a potential role to play in some countries, but unless made compulsory, will likely remain a niche market. So unless made compulsory, I think, is the interesting phrase in this quote, because if you make it compulsory, it's no longer a private insurance, because if you make it compulsory, you also need to subsidize the low-income groups, because otherwise they can't afford it, and if you make it mandatory, they have to afford it, you have to subsidize them, and then what results from that is a kind of social insurance. So my conclusion at this point, we need public involvement of some sort. Question then is, of some sort, do we need the same solution in all countries? And I don't think so. What we have up to now is not all citizens can afford necessary long-term care. At least a system of social welfare is needed as last safety net. That's, so to say, the minimum we need in all countries. The existence of such a safety net, on the other hand, will crowd out the private insurance that's there. So if you want to, it's a kind of Greek tragedy, because you need a safety net, but by introducing a safety net, you ruin the private insurance, and you need a safety net even more. So, question, is a last safety net enough, or do we want more? And questions that relate to that are, if we want to have public involvement, what could be the role of means testing? What could be the role of tax versus social insurance financing? What is the role of funding versus pay-as-you-go? And I start with means testing, and for people with risk aversion, means-tested social welfare, of course, is only a second-best solution, because if you are risk averse, the best world you can live in is one in which you have the same amount of income and assets, irrespective of whether you are in need of long-term care or not. With social welfare as the fundamental security system, you will never reach that. The second problem that might occur if you rely on means-tested systems is fiscal federalism. If municipalities or provinces are responsible, as is often the case, this might cause fiscal stress. And once again, looking at my own country in Germany, I would say this fiscal stress was the one reason why we introduced long-term care insurance in 1995. We discussed it for 20 years with all kinds of social policy arguments, but what was really behind it was what you can see on this table, the increase in expenditure from here to there of municipalities and provinces for long-term care, for social welfare for people in need of long-term care. And that puts the pressure on the federal government to introduce long-term care insurance. And I think in Austria, recently we observed something similar, at least a similar debate, as the cash benefits, the cash allowance is not sufficient to finance nursing home care, and the provinces once again have to finance that, and they are heavily burdened, and we have a debate of how can this be remedied. So fiscal federalism might always be a problem if we rely on means-tested systems. The central question, however, is when we talk about means testing, and do we want means testing, do we want a system based on means testing, the central question is what kind of welfare state do we want? And if we distinguish the liberal and the conservative welfare state, with the liberal welfare state aiming at preventing poverty and preventing insufficient medical and nursing treatment, then of course you can say means testing is quite all right. Means testing guarantees that the benefits are only going to those in need, only those who have insufficient income and assets. That's fine. If you, on the other hand, believe in a conservative welfare state, where status maintenance is the underlying principle, where the principle is once you have worked during your whole working life for 40 years, worked hard, and then you attained some position on the social ladder, that should be protected. That's the basic idea of a conservative welfare state, saying in old age, I want to remain who I am, and irrespective of whether I'm ill or in need of long-term care or if disability occurs or whatsoever, I want my position to be protected against these risks. And if that's your underlying perception of what a welfare state should be about, then of course means testing is not a suitable means. And I think we have to keep that in mind. What are our perceptions? What do we want of a modern welfare state? Do we want it just to prevent poverty, or do we want it to prevent to guarantee a status maintenance? And depending on how we answer this question, we of course should answer what the role of means testing and also other forms of cost sharing should be. Let me go on to the next question, taxes versus social insurance contributions. As I tried to argue by now, private out-of-pocket payments is not sufficient for financing long-term care. Private voluntary insurance is not. It's those two types that are real candidates for financing long-term care. And with taxes, they include direct taxes, indirect taxes, and taxes generate no claim for specific benefits, which means for taxes the willingness to pay is always limited, while social insurance contributions are earmarked, are not part of the general state budget, contain some element of redistribution, and that is why a lot of people say the willingness to pay is better for contribution because you get something back. Taxes have some advantages, have some disadvantages. Advantages, they're levied on the whole population, on all kinds of income. They are potentially redistributive. The disadvantage, the major disadvantage, that's at least what everyone from a conservative welfare state would say, is revenue may decrease in times of budget crisis because you have no constitutional guarantee of these benefits. Taxes are particularly compatible with liberal welfare states and means testing, or to put it the other way around, if you want to have means testing, you must rely on taxes because you cannot rely on contributions. Contributions always give you some claim irrespective of your income and assets. Social contributions have advantage. They are earmarked, they are safe in economic crisis, higher willingness to pay. They have disadvantages, particularly if this system is not properly designed. And here I have to refer to Germany, where I would say our social insurance system is not properly designed because only 90% of the population are in the system. 10% could opt out, and those 10% are healthier and wealthier. Also, contributions are not paid from all of your income, but only from labor income, which creates all kinds of tensions in the labor market. So those are disadvantages of social insurance contribution, particularly if the system is not properly designed. Of course, there's a close fit between conservative welfare state conceptions and social insurance because benefits are based on contributions. You only get something if you pay something before. Benefits may guarantee status maintenance. Depending on the normative conception, once again, of the welfare state, either or the other one is more suitable. Let me come to the third point here, funding versus pay-as-you-go. Of course, pay-as-you-go systems might have some advantages. They are flexible to changing environments. For example, when the German unification happened in 1990, it was not a problem to extend all the social insurance systems to the east of the country. If we had funded systems, it would have caused a tremendous trouble because, of course, in Eastern Germany there haven't been any funds. Yeah? The major advantage for pay-as-you-go systems, of course, is that there are immediate benefits. Once you introduce the system, you have benefits at once. And that's the disadvantage, number one, for any funding system. When you introduce it, you either have to wait for some time until you give benefits, or you have to have very high premiums because you want to build up the fund and at the same time pay something. And that's why the introduction of funded systems is very unpopular with politicians, and I'm not aware of any case when a new system was introduced that it was introduced as a funded system, a long-term care system, a public system, because for politicians it's very unattractive. So that's why we hardly see universal system based on funding. Funding is more likely as a supplement to a pay-as-you-go system, and I will come back to that right in a minute. Before I come back to that, just one question, question number 3. What are the major challenges for text-based and for social insurance systems? And of course, there are some fundamental challenges that apply to both kinds of systems, namely how to control expenditure and how to secure willingness to pay, or to pay ever more, because that's what's happening in the wake of the demographic change. How to control expenditure? There are certain regulations we can use for that. The eligibility criteria, the definition of long-term care, that's something we can modify. We have to take care of moral hazard, particularly if cash benefits are in place. We must be sure that we don't have moral hazard. I think the only way where we can really save money is with respect to care arrangements, the role of informal care and migrant care. Though in this morning we learned that we have not enough information to really base recommendations on that. But I think economics of long-term care, that's the only way we can really save money. Apart from that, we can only try to secure willingness to pay. And so what are the challenges for social insurance systems and for tax-based systems? For social insurance systems, when being introduced, you can decide, should the contribution be risk-related, income-related, should it be flat? And once in place, what you have to do is secure a broad financial base and secure substantial benefits and proper adjustment, particularly if you have capped benefits. For tax-funded systems, challenges are which kind of care you should have means tested and which kind should be not means tested. In Britain, I think that's a constant debate from the Royal Commission's report in 1999 to recent debate. How should we finance personal care, medical care, social care, England different than Scotland? And if you have a means-tested system and a not means-tested system besides each other, that's something you are permanently trying to balance. How to guarantee sufficient benefits in cases of economic crisis. We have seen that also in the 2008-2009 crisis. Those countries relying on tax financing were tempted to cut back benefits in long-term care and also in health more than those countries with social insurance systems. And finally, how to uphold redistributional effects of taxation when we observe throughout the world that direct taxes are on the retreat and indirect taxes becoming ever more important, which do not have a lot of redistributional elements. But now to what I think most pressing and most interesting question: how can different means of financing be combined? And I've put out 3 points here. First, tax financing in social insurance schemes. And of course, in social insurance schemes, if there are capped benefits, if there are co-payments, if there are these kinds of cost sharing, there will always be a last safety net. That means even in a social insurance system, you need something like social welfare. Another element of tax financing you have in systems with flat contributions, like the Netherlands and Switzerland in healthcare. If you have flat contributions, everyone is paying the same amount of contribution. You need subsidies for those with low income. And the third way tax financing can play a role in social insurance is to compensate for benefits that are not regarded as purpose of the insurance. That's something that's very important in the German case, particularly in pension insurance. About 1/3 of the revenue now comes from tax money. And the argument always is that the pension insurance pays a lot of benefits that do not really belong to pension, but are family benefits and so on. And then there is some tax money going into that to compensate for this. That's a prominent in pension insurance. We have it in health insurance. We discuss it for long-term care insurance. Okay, chances of supplementary tax financing, of course, is that it's invisible. That means you can do that without making it so much public. And the danger of supplementary tax financing is the political instability of revenue. Coming to funding as part of a pay-as-you-go system, some people have asked me to elaborate a bit about the German system, and I'm happy to do that. Though Matthias Schwanflügel had done it in a session before, but I think if you hear both of us, you might have a good impression of what's really happening in Germany with funding in a pay-as-you-go system. And starting with the basics, until 2013, we had about 90% of the population in the mandatory social insurance, 10% of the population in the mandatory private insurance, and then we had additional supplementary insurance that could be bought by both groups, and by and large, 2 to 3% of the population bought that. Since then, we have introduced two new mechanisms for funding in long-term care. The one is named after the health ministry at the time, Herr Bahr, that's the Pflegebar, and the supplementary subsidized voluntary long-term care insurance. And from 2015, from January 2015 onwards, we will also have a collective provident fund within social long-term care insurance. So two mechanisms for introducing funding schemes, one in the private, one in the social insurance. So what is it, this Pflegebar? It means that there's a tax-financed subsidy of €5 per month on contracts that fulfill certain conditions. They have a premium of at least €10 per month. They have benefits of at least €600 in care level 3. No obligation in care level 1 and 2. Obligation to accept every applicant not yet in need of long-term care. No medical underwriting, but age-specific premiums. And the waiting time no longer than 5 years. That means 5 years after you have done this contract, within the first 5 years, you won't get any benefits. So that's the regulation of this Pflegebar. So what should we think about that? And I think this system has a lot of problems, and which are symptomatic for this kind of supplementary private insurance. The number of insurees will be limited. For 2013, the government had put aside €90 million, would have reached for 1.5 million contracts, and in the bill it was said we expect 1.5 million contracts by the end of 2013. In fact, we had 400,000 contracts. That's about 1% of the working population. In the long run, no one estimates more than 10% of the working population. Due to social welfare, insurance is unattractive for households with low income. That means those who buy those insurance are the better off, which means since it's tax subsidized, we have a kind of perverse redistribution that the poorer finance the subsidies for the better off. We have very insufficient benefits. What you can see here is in nursing homes, what you have to pay out of pocket at the moment. And those are the benefits of the Pflegebar according to the recommendations of the insurance companies. And you see that's the remaining gap once you have this bar insurance. And in level 1 and 2, it's hardly any difference, of course. And in level 3, it's still very high. So it's insufficient. And we have the problem of adverse selection. The new insurance is particularly attractive for those who could not buy the normal insurance. Due to this risk selection, premiums must be higher. At the moment, they don't appear to be higher, but that's because the insurance companies are safe, as waiting times works as a safety net for them. Within the first 5 years, nothing can happen, and later they can increase their premium. The biggest danger, however, is that the Pflegebar might legitimize insufficient adjustment in social long-term care, that politicians say, we cannot afford to adjust properly, but if you need something, there is the private subsidized insurance. The second mechanism that's new is the Pflegevorsorgefonds, starting in January 2015 it should read. From 2015 on, contribution rate is increased by 0.1 percentage. That gives the contribution rate at the moment is at about 2%, and it will be increased on 0.1 percentage point. The revenue generated from that is about 1.2 million euro. This additional contribution is collected for almost 20 years, and managed by the Deutsche Bundesbank, which is always important because that's one of the institutions everybody trusts. So if you can say it's the Bundesbank, you are safe as a politician. From 2035 onwards, a maximum of 1/20th of the capital reached then is given to social long-term care insurance to prevent increasing contribution rates. And once all that is spent, the fund will be closed. So it's a temporary mechanism. Once again, what are the effects of these Pflegevorsorgefonds? First, the quantitative effect is very small. For 20 years, the contribution rate is increased for 0.1 percentage point. For another 20 to 25 years, it's then reduced by the same amount. It's difficult to protect such a fund against politicians once there's a financial crisis. Nobody really believes that you can put aside that amount of money for 20 years. And thirdly, the fund will be empty when we have the highest number of beneficiaries. And while the number of beneficiaries will increase, it will decrease from 2050, 2060 onwards. The contribution rate will not, because the contributors will also be much less. Because since 1970, we have a fertility rate of 1.4 kids per woman, and that's constant for 40 years, and nobody is expecting that to change. That means in the mid of the century, the demographic transformation is finished, and then the contribution rate should be constant, and that's how projections look like. We have increasing contribution rates here, and then it will remain like that forever. And now you can easily imagine what happens to this Pflegevorsorgefonds. That's the calculation done by another group of researchers in Bielefeld, and that's the effect of the Pflegevorsorgefonds. Here the contribution rate is a bit higher, here it's lower, and then it remains as it has been. So that's a kind of policy which I can only say is very close to window dressing. So, final question here. What can be the role of supplementary private insurance scheme then? I think supplementary private insurance scheme are an instrument, the last slide, for the better off. That's particularly true for immediate long-term care insurance annuity plans. For covering gaps in the public scheme. For those, they might be helpful, but we must make sure politicians don't cut public schemes and refer to private insurance instead. If we, however, no longer want to rely on means-tested social welfare, I think social insurance is much superior to private insurance. That's the question you asked in the last session, Josh, saying why should we make private insurance work? And I can only support you in that. If we don't want any longer relying on means testing, saying, oh, that's not fair because you have to spend down all your assets and whatsoever, then we need a public mandatory scheme rather than trying to make private insurance work. And that's what I wanted to say in this presentation. We need some sort of public involvement. Distinct welfare state conception demand distinct means of financing long-term care, particularly the role of means testing depends on that. There are specific challenges for social insurance and tax-based systems. In long-term care, funding can at most be supplementary. Private insurance might supplement public scheme. However, this contains a lot of dangers, and I would rather prefer mandatory social schemes rather than private insurance. Thank you very much.
Okay, we have some time for questions.
I want to ask if you think that mandatory social insurance is necessary, and given the criticisms you have made of the existing social insurance system, including the window dressing that you rightly have described, what do you think, or what do you reckon would be the contribution rate that would be necessary to fund the level of provision that you think is going to be required, and if we do have this contribution level, what are the implications for it as a tax on labour, given that there are potential distortions as a result of taxing labour? And given that we know that the government is being terribly careful about trying to contain labour costs that are and taxes that are levied on labour because they think that this is dangerous to incentives, either demand or supply incentives.
First, it will become more expensive. We can't change that. And the question is only how to finance it. It will be more expensive anyway. Second, we have done some calculations for the German case. Contribution rate of about 4% will be sufficient to finance the current level of care plus some extras. 4% it will be. The third, I agree with you that it's difficult to have it as a labor market payroll contribution. We should have the contribution of all kinds of income. That means also income from interest, from houses you give to other people and stuff like that.
Other questions?
Yes. First, thank you for an excellent overview of important issues. I would like you to say something more about the relationship between tax financing on a pay-as-you-go basis versus mandatory social insurance. In my country, Norway, even despite the impressive fiscal sustainability now, India heading against very high tax rates, perhaps prohibitively high tax rates. I think that the argument, willingness to pay, may be much more important in the future than it is now. Could you elaborate a bit on that?
The standard answer from someone from the social insurance system would be that, of course, for taxes, that's money you give away and you get nothing back. I mean, nothing in particular, of course you get something back and you don't know what. But if you can argue that the contribution rate is for long-term care, you have a high probability of being in need of long-term care at some point yourself, that's for these and those services, but then the willingness to pay is higher. That's one of the arguments for social contributions rather than taxes. And I think that's more or less what you said.
Yes, I noticed that the Swedes, they returned to an autonomous pension budget in their reform, and that was exactly the reasons why they did it.
Yeah.
So one of the things I've become alert to as I've looked at different countries is the extent to which local government provides basically means-tested support to wrap around whatever the national government provides. So particularly room and board costs for people who are poor in residential care. And when looking at what was going on in France, the relationship between the Departement and the national government has been one of the key movers, the drivers of policy, because what ended up happening is that the departments are picking up so much of the cost of the long-term care program and the excess costs associated with the costs that the national government doesn't take up. And certainly in the United States, there's extreme variation from state to state in terms of what people get depending on where they are. So I just want to sort of factor that into the picture a little bit. I mean, what role should local governments be playing? And if you're talking about means-tested, I mean, de facto, Germany has a means-tested program because of this role of local government. So how does that factor into your model?
Yeah, I think there's two questions. One is the role of local and central government, and it depends on the country. You have a strong federal system in the US, and you cannot compare it with England. And so the argument I was trying to make to say the system must fit into the general political system, the general welfare system applies here. So I don't think we can have one answer saying this is the amount of local and central that is right for all countries, but it has to relate to the traditions of this country. And with the role of means testing, yes, in the German case, we still have means testing social welfare, and as a safety net. And I would always argue that we must make sure that long-term care benefits, long-term care insurance benefits, are sufficient so that the last safety net is really a last safety net for a small minority, and then not for the majority, which it was before 1995, where it was the financing needs of 80% of the population in nursing homes in 1993. That's nothing I would appreciate.
So we have time for one last question.
Thank you for the excellent logical argument, to make a case for social insurance. But then I am more thinking, for the middle income country, we talk about in Margaret first presentation, that we don't have the pay-as-you-go system. We only have a tax-based financing system, which is non-mean-tax. So for the next step, would you recommend more the social insurance model, a mixture between social insurance, pay-as-you-go model, or what?
I think social insurance schemes normally are organized as a pay-as-you-go system, and particularly in Asia, we have seen the introduction of pay-as-you-go based social insurance systems in Japan, in Korea. I've learned in Taiwan, we are expecting to have it. I know in China there is a lot of discussion about social insurance scheme. So I think particularly for Asia, pay-as-you-go based social insurance scheme is an option, and which is taken up in these countries.
But it doesn't solve the problem when the population dynamic change, you have fewer income than expenditure.
Yeah, but that's the underlying problem with demographic change. And I mean, China, for example, has demographic change to some extent. That's enormous to expect in the next couple of decades. If we have more older people, more people in long-term care, it will be more expensive. And we cannot discuss that away. And in the social insurance system, you can see that from contribution rates. It will go up. But I don't know how that can be avoided, sorry.
Julian, you want to ask one last?
Thank you. You didn't say much about, and this is linking back to some of the previous presentations, especially on informal care, because it strikes me that one of the things that we've been grappling with over the years in England and the UK is the role for care of blindness or not of your system. And in particular, although you're talking more around the financing side, it's very difficult, and it may not be appropriate anyway, to build in any degree of care-sightedness into a social insurance system. Where you've been inventive in Germany in the way that that's been done by changing the contribution rates for childless couples and having the cash payments set at lower levels. But in England, you can just very explicitly have the benefits paid out, which take account of the caring situation of the family involved. And so I just want, I see that as quite an important distinction between a tax-based system and a social insurance system.
I'm not quite sure about the last sentence. I would just want about to agree that, of course, I only talked about the financing system, not about spending, and I think we should concentrate more on spending, think about the role of informal care, and I think that's where economies can be made with the care arrangements. So I'm completely with you with that. I didn't touch it because it wasn't the topic. I had more than enough to do with financing rather than talking about spending. But I'm not quite sure how tax financing, social insurance financing relate to the kind of spending, because in social insurance systems we have cash allowances. We have in Austria we have only cash allowance. In Germany we have cash allowance and in-kind benefits. In the Asian countries we have only in-kind benefit. So everything goes with social insurance contribution. So I don't see the close link you seem to.
So maybe you can continue that discussion afterwards. So,